Good afternoon, everyone. Thank you for joining our webinar this afternoon, hosted by the American Heart Association Southwest Affiliate. My name is Larissa DeLuna, and I will be facilitating our webinar for today. First of all, just to start off with a few housekeeping rules, I'm going to be putting everyone's lines on mute for the duration of the webinar to avoid background noise. If you'd like to ask a question, feel free to use our GoToMeeting type in a question functionality, or feel free to unmute your line with *6. We will also open all the lines at the end of the call for questions, but please feel free to use those two functions to answer questions during the webinar. We'll go ahead and get started today. Our featured speaker for today is Dr. Larry Allen. Dr. Allen grew up in Denver, completed medical school at Harvard, medicine residency at Massachusetts General Hospital, then a cardiology fellowship at Duke with specialty training in transplantation and mechanical circulatory support. After a brief period on faculty at the Duke Clinical Research Institute, Dr. Allen moved to his current position at the University of Colorado School of Medicine. Dr. Allen splits his time between clinical duties in the section of advanced heart failure and transplantation and research activities with Colorado Cardiovascular Outcomes Research Consortium and Kaiser Institute for Health Research. Dr. Allen's goal is to promote appropriate and patient-centered use of therapies for heart failure, help patients and clinicians recognize the transition into advanced heart failure, and improve the quality of care for heart failure patients at the end of life. Dr. Allen, thank you for joining us today. I'll go ahead and turn it over to you. I'm going to mute everyone's line really quick.
The conference is now in silent mode.
All right, Dr. Allen, go ahead.
So I want to thank all the participants who are here today. I also want to thank Larissa and the American Heart Association for their invitation today to talk about, our work here at Colorado trying to improve quality for heart failure and to really share experiences across institutions for how to do this better. I have about 40 slides that I'm going to go through today that provide some data on evidence-based beta blockers to give us context for why we're doing this. And then I'll finish the talk talking about some of the things that we're doing here at Colorado. But in the end, I want to save some time at the end to go through the questions that come in so that we can have a bit of a discussion about how to do this at each institution and what we can learn from each other. So these are my disclosures, and probably the most important disclosure is the bottom one, which is that I don't have all the answers, and I really don't think anybody does. As you know, quality improvement and taking care of patients always can be better, and we always have new challenges to work through. So again, this is a process, and it's one that we need to remain committed to and need to continue to learn from each other about how to do it well as times change. So the summary for today is, first I want to talk, why are we talking about beta blockers specifically and this measure among all the heart failure measures? And I'll do that within the context of what the central kind of evidence-based medicine is for heart failure with reduced ejection fraction. And then I'll spend a little bit of time talking about why we have this, why we aren't just talking about beta blockers, but rather why we're talking about evidence-based beta blockers. I want to talk a little bit, too, about why this is not just important for patients, but for providers and hospitals. And then perhaps most importantly, we want to talk about what it is that we can do in terms of practical considerations for the delivery of care, but also various people's experiences, and then how we can leverage health information technology to potentially help us with this. So the Get With the Guidelines heart failure achievement measures are really designed to help us focus on those things that are have been shown and proven to help patients with heart failure do better. And most of you are familiar with these if you're participating on the call. But just to refresh your memory, there are a variety of measures that are out there, and one of them is to see that patients are prescribed a beta blocker if they have a reduced ejection fraction. And you can see that when Get With the Guidelines was really started, when people were initially signing up, this was something that was done relatively well at nearly 9 out of 10 institutions. And with time and the work of Get With the Guidelines and the participation in the program, that has come up to almost 100%. A couple of caveats about that. One is that I think beta blockers are some of the best medicines that we can use for people, and so we should really strive to have a very high compliance with this measure. The second thing, and the reason that Larissa and the AHA actually set up this talk, is that even though we initially saw quite a bit of improvement in this measure, lately there's been some slippage in it. And I think that raises concerns about making sure that this very well-proven therapy it continues to be used in people it should be used, and to think how we could do a better job at maintaining this high level of performance. So I wanted to go back to the evidence because I think there are so many things that we can do as hospital programs to take care of our patients for heart failure. And some of being a good healthcare provider or being a good hospital institution is to triage all the things that we can do and really make sure that the things that have the best evidence for them are the things that we prioritize the most. So I want to go through the beta blocker data because I think it's good, but it also helps us understand some of the nuances around the prescribing of beta blockers and maybe where some of the problems can come in. So again, if you would like to get additional information on the recommendations around beta blockers, the American Heart Association, in conjunction with the American College of Cardiology Foundation, has recently updated their guidelines in 2013, which most of you are aware. But again, these kind of guidelines provide an extensive amount of data summary and have all kinds of information in them. And so this is not a one-time read. In fact, I think it's hard to read them at once. But it's an iterative process where you come back to them over and over to help refine what it is that it really is the standard of care for these patients. And I think a couple of comments. One is that I came back to it just to refresh myself for this talk, and I always learn something going to the guidelines. The second is that I think the 2013 iteration is a significant improvement actually over prior iterations for a couple of reasons. I think Clyde Yancey and some of the others who were in charge did an excellent job of really trying to think about how to make this practical and useful. And so when you go to the guidelines, you'll see that there are, I think, easier to use tables, and that some of the algorithms that are provided are actually much more clinically oriented or practical. So I would encourage you, not in thinking about beta blockers, to get data on beta blockers, but also just in general to use the guidelines to help you do that. The second is that I actually think referring to the ESC guidelines can be helpful as well for some people. Obviously, Europe is not America, but the data is the data, and so there's a lot of overlap. And I do think seeing a different take or different figures or different algorithms can be helpful, and the ESC guideline is excellent as well, and I think some of the figures they have are quite good as well. So one of the other key features of the new guidelines from the ACC-AHA is this concept of triage, or focusing on those things that are the most important or that form the foundation of care for patients. And so they come up with this term called GDMT, or Guideline-Directed Medical Therapy. And essentially what it says is that if you're taking care of patients with heart failure, those patients who have a reduced ejection fraction and symptoms of heart failure, that there is extensive evidence out there for a few key therapies, and that should be the focus or the foundation of what you do for these patients. So if you have patients who have documentation of low ejection fraction, less than 40% or moderately or severely reduced, and they have had symptoms in the past, so they could even be asymptomatic now, but clearly have evidence of heart failure, that those patients should really be on an ACE inhibitor or ARB and a beta blocker. And that is where you should, to some extent, start because the data is so strong for that. And then in addition to that, beyond those two therapies, volume control is critical for keeping people out of the hospital and having them feel good. And then consideration of an aldosterone antagonist like spironolactone or eplerenone and or hydralazine nitrates, particularly in African Americans, is really the foundation of care. So that's part of the reason we're talking about beta blockers again today, is that it's so important that we do that well since the data is so good for it. Part of the reason that this focus on GDMT came about is that if you look at the data, not only is there a lot out there for these key therapies, but the relative risk reductions in both mortality and hospitalization are quite impressive. And across the board, beta blockers have as good or better data than any of the therapies that are out there. So essentially, if you have a patient with symptomatic heart failure and a low ejection fraction and you treat them with a beta blocker as opposed to not doing that, the reductions are really up to a third in the event rates. So if event rates are 1 in 3, so over a few years, if 30% of people would die, you reduce that by a third. So you really only have to treat about 9 people to save a life and prevent hospitalization. The other data I think that's important about beta blockers is how well these therapies apply across the spectrum of low ejection fraction heart failure, or HFrEF. So, that we spend a lot of time thinking about what's the etiology of the patient and what are some of the nuances and specific issues that are going on. But to some extent, beta blockade in patients with low ejection fraction is pretty consistent in terms of the benefit that it offers. So one of the ways to think about this is if you have patients that you enroll in a trial who are very stable with low NYHA association class, or if you apply beta blockade to people with high symptom burden and high NYHA class, even into NYHA4 with the Copernicus study, you see that the relative risk reductions are pretty consistent across that. So to some extent, this simplifies our approach because anybody who has had some symptoms of heart failure and a low ejection fraction is probably going to benefit in terms of relative risk reductions pretty equally from beta blocker. And remember that the more sick patients are, the higher their NYHA class, the greater their absolute event rate. So a 35% relative risk reduction is, in terms of absolute numbers of lives saved and hospitalizations prevented, is greater in those sicker patients. So we really should be thinking about beta blockers for all these patients. The second issue is that it almost doesn't matter how people got their ejection fraction down, that patients seem to benefit relatively equivalently whether they had a heart attack or they have dilated cardiomyopathy from idiopathic etiology or whatnot. So again, this simplifies it in the sense that we can talk a lot about what the ischemic burden is and there are implications for that, but in terms of thinking about a beta blocker use, it's not so important and it actually simplifies our approach. And then finally, when we look at the different drugs that are out there, we'll talk about carvedilol versus metoprolol succinate versus the CBIS trials with bisoprolol. But if anything, the generic drug carvedilol seems to do as well or better than some of the other drugs. Now, again, those are the 3 drugs that are approved. You'll see on the left, carvedilol, metoprolol succinate, and bisoprolol have all been studied in some of the studies that were just shown. But this is not necessarily true for all beta blockers. And so that's why instead of talking about beta blockers in general, we talk about evidence-based beta blockers, and those are beta blockers that show a significant benefit that's in the range seen with other beta blockers in patients with low ejection fraction. And I'll show you some trials in just a second that show that other drugs may not, that are beta blockers but are different beta blockers may not be the same. So perhaps the most important study is the Comet trial. And this trial is a comparison of carvedilol with metoprolol tartrate, or low pressor, the short-acting beta blocker that, quite frankly, has been used extensively in the last 20 or 30 years by providers. What's really interesting about this study is that there are relatively few studies of drugs where there are large randomized controlled trials that look at clinical outcomes like mortality and hospitalization that compare within a class of drugs. So comparing a beta blocker to a beta blocker in this case. We don't see too many trials that compare similar drugs. And part of the motivation for this is that beta blockers are not all the same. They affect beta and alpha receptors somewhat differently. They have different lengths of duration in terms of their pharmacokinetics. And so there was some thought by these investigators that there may be a difference in terms of clinical benefit between these different drugs. So they designed this trial, Comet, and what they found was actually that over many year period in patients with low ejection fraction and symptomatic heart failure, that if those patients were randomized to carvedilol, they had a significant reduction in their outcomes relative to the patients who randomly got assigned to low pressor or the short-acting metoprolol tartrate. There's been a lot of discussion about this study, but needless to say, I don't think a similar trial will be done in the near future. And overall, this trial was relatively well conducted, and so because of it, we in the AHA and other people feel that there are differences in the beta blockers, and that carvedilol and other drugs that have a similar benefit in trials should be preferentially used over metoprolol tartrate or other drugs that have not been studied. Another couple of studies have been done as well with other beta blockers. So, and two studies in addition to Comet to highlight are first the BEST trial, which was largely led by Mike Bristow, who is here at University of Colorado with us. They looked at bucindolol, which is not a drug that you will see very often because the BEST trial was negative. Essentially, patients were randomized in the era when we were learning about beta blockers with low ejection heart failure patients to bucindolol or placebo. And what you see is that in this trial it was negative, that the benefit was small enough that it wasn't statistically significant, and the benefit that you see is significantly less than what is seen with the approved three drugs, carvedilol, bisoprolol, and metoprolol succinate. The other study that's important is the seniors trial, and I think this is to some extent more relevant clinically because nebivolol is approved and is used for hypertension, and so you will see it being prescribed clinically. And just note that, again, in the seniors trial, looking at older adults, both with low ejection fraction and normal ejection fraction, that in both of those groups, nebivolol didn't seem to have the same level of benefit as seen with the three approved drugs. So, again, the key is that when you're thinking about beta blockers for patients with heart failure and reduced ejection fraction, not all beta blockers are the same, and there are three that you should keep in mind, and they do not include these because of the studies you see. So, again, with that information and that data in hand, the new guideline from the AHA-ACC in 2013 to some extent makes life simplified, which I think is overall a good thing in the complex clinical care that we provide. So the beta blocker recommendation is really just one. It's a Class 1A recommendation. It says use of one of the three beta blockers proven to reduce mortality, which are, again, bisoprolol, carvedilol, and the extended release long-acting metoprolol succinate, is recommended in patients with current or prior symptoms of heart failure and reduced ejection fraction, unless contraindicated, and we'll talk about that in a minute, to reduce morbidity and mortality. So it's important to know what the kind of the dosing was in the trials that were used and how they got there. So most people who take care of these patients obviously know that prescribing a maximum dose of the drug up front is generally not particularly well tolerated, especially in patients who either have symptomatic heart failure or lower blood pressures. And so in the studies, these were generally started in the outpatient setting in relatively stable patients, although they may have, most of them had symptoms. Were started at a low dose, which you can see here is the initial daily dose, and then generally titrated upwards, no more than doubled every 2 weeks. Another important fact is that not everybody could tolerate a maximum dose. So there was some discontinuation rate, which was relatively small. But there was also, even among the majority of patients who were actually on the drug, they may not have been able to get to the top dose because of either decreases in blood pressure, decreases in heart rate, or symptoms that were attributed to the drug. So generally they got to about 70 to 80% of maximum dose on average. A couple of caveats when you think about prescribing beta blockers. So, like I said, it's pretty simple. Anybody who has a low ejection fraction, has had a history of symptoms, should generally be on a beta blocker. But we do need to be careful about getting there, and there are important contraindications. So one of the ways that I think about this is as a clinician taking care of patients, or as a chart abstractor for Get With the Guidelines, thinking about our quality measures, or as a coder who's thinking about how to decide what a patient in the hospital should have as a primary discharge diagnosis, which affects our quality metrics because that becomes the denominator. We have to think a little bit about heart failure types. And just remember, when we talk about heart failure, this means a lot of things. So it's a clinical syndrome experienced by the patient, but we should break it down into important categories. And I tend to do it this way when I teach it to house staff and medical students, which is that we can think about the heart a couple of different ways. One is that there's a right side and a left side. And so we've had a lot of issues with, at our institution, with patients who have primary pulmonary hypertension or really have significant lung disease, who then develop right ventricular issues and then have volume retention related to cor pulmonale being coded as heart failure. And to some extent that's fair, but it can create some issues around whether these patients qualify for certain quality measures. And so we've worked with our coders and our abstractors and even our clinicians about how to make it clear what type of heart failure we're talking about, and if it's really a pulmonary process, to work on making sure that it is clear this is really a right ventricular problem and a cor pulmonale problem. The second we already talked about, which is if it's a left-sided issue, we talk about left-sided issues related to the left ventricular ejection fraction, and I actually prefer, when I document and talk about it, to actually include LVEF rather than just EF, because EF could mean a lot of things. It can refer to the right ventricular ejection fraction, and I've even helped correct coding for people who've had gallbladder scans and talked about the gallbladder ejection fraction, not to get too distracted. But we're really talking about in HFrEF and HFpEF whether the left ventricular ejection fraction is reduced or not. And then finally, the third way to break this down is to think about patients who have chronic or relatively stable symptoms versus those who are acute. And typically when we talk about acute, we're talking about exacerbations of existing heart failure that cause worsening symptoms that are typically enough to cause a patient to seek emergency or urgent care and often result in hospitalization. The reason this is so important is that in terms of therapies, the GDMT, or the real good evidence we have for basic therapies, typically apply to heart failure with reduced ejection fraction in patients with chronic stable heart failure. And that's where those studies were done. With Get With the Guidelines, we're typically talking about hospitals with patients who are acutely hospitalized. And there the data may not be as applicable, or at least we may need to interpret it slightly differently. And then if we're thinking about patients who have normal left ventricular ejection fraction or have right heart failure, that's a whole different animal when it comes to beta blockers and many of the therapies that I mentioned before. And so it's just so important to keep in your mind as either as a clinician treating patients and documenting, or as some kind of as an abstractor or coder or even a hospital system, that we can't just talk about heart failure. We've really got to talk about the type of heart failure that's going on, because that's going to dictate our therapies and thus whether we're meeting our quality metrics. There are important side effects of beta blockers as well, and so we have to think about these in terms of both applying beta blockers to our patients and whether our patients should be in the denominator for quality metrics. So bronchoconstriction is obviously a concern. It actually is relatively rare in most studies and randomized trials when patients with emphysema or COPD were placed on beta blockers. If they had relatively stable COPD, the risk of a COPD exacerbation is low. But generally, for patients who have significant bronchoconstriction or reactive airways disease, you should think about using a beta-1 selective beta blocker, and I'll show you some data about how to choose between the three based on that. People often talk about fatigue, sexual dysfunction, and depression on beta blockers, and what I will say is, obviously, as clinicians, we need to think about those side effects and listen to our patients and how they're responding to their drugs. And as coders or abstractors, we need to recognize that those are possible reasons why a patient might not be on the drug as a contraindication. But I do want to make it clear that fatigue, sexual dysfunction, and depression are extremely common in patients with heart failure, especially with low ejection fraction. And the absolute increase in these symptoms when a beta blocker is started compared to placebo is actually quite small and not significant in most analyses. So again, the main take-home message is we think about these things, we ask about them, but the benefits of beta blockers are so large that we need to be careful that we don't quickly assign these as contraindications and deprive our patients of the potential large benefit of beta blockers due to side effects that are not actually side effects but just symptoms of the disease they have. And the last thing is that the effect, whether you want to call it a side effect or a desired effect, is that beta blockers are acute negative inotropes and chronotropes. And the way I like to think about this is that our goal in treating heart failure patients who have symptomatic heart failure, who have had that, who have structural changes to their heart with low ejection fraction, is really to calm the heart down and allow it to be unstressed over long periods of time. And so, this is kind of in the long-term view is the tortoise and the hare view, which is that we really want to think of heart failure with low ejection fraction as us being the tortoise and taking a long-term approach and slowing things down and giving the heart a chance to respond. This gets very confused, I think, in patients who present to the emergency department with severe exacerbation and especially shock, in the sense that those patients no longer have a long-term view. The goal is a very short-term one, and that is to stabilize the patient, make sure they have an adequate blood pressure, get excess volume off through diuresis if possible, and get them to a better place where we can then reassume our long-term view. And so when patients present acutely and are not doing well, again, we have to readjust our focus, and that does not necessarily include a beta blocker. And this is where clinical experience and clinical judgment is incredibly important in determining the role of beta blocker, because in a patient who really is in shock, a beta blocker is not appropriate. But obviously there are a wide range of shock and instability, and we have to reevaluate our patients, use the data we have to figure out where they are on that spectrum. And so the general teaching is that patients who come in with a very mild exacerbation who are doing well should have their beta blocker continued. But patients who come in who are somewhat unstable, we can try and continue, but sometimes we have to back off on the dose, maybe half or slightly. And in patients who have inadequate blood pressure, especially with end organ damage, such as shock liver or acute renal failure, we need to think about actually potentially withdrawing beta blocker, or especially not stopping, and sometimes even moving to inotropes. And so as clinicians, this is determining who those patients are, which is actually a very small minority of patients, and treating them appropriately is important. And as coders and abstractors, recognizing when a patient is hypotensive with shock and end organ dysfunction, and that being a reason why they have a long hospital stay and may not be on a beta blocker, ACE inhibitor, etc., that's reasonable. So these are the listed contraindications. Again, cardiogenic shock, as I just mentioned. One of my pet peeves is when patients get transferred to our tertiary kind of advanced heart failure program, and they are on dobutamine drip as well as having their carvedilol 25 milligrams twice a day continued. Again, that to me shows that people aren't necessarily recognizing shock, nor the antagonistic actions of a beta agonist and a beta antagonist. Again, we already talked about severe reactive airways disease, but this should be relatively rare also. So shock and severe reactive airways disease are rare. And then I think occasionally we see patients who have excessive bradycardia or pauses that can be exacerbated by the beta blocker effect on the AV node. Again, we start at very low doses and up titrate to goal, and these patients need to be monitored over time. So a couple of other caveats is that we talk about this cutoff of HFrEF as having an ejection fraction of less than or equal to 40%, but again, heart failure isn't nicely divided into HFrEF and HFpEF, and this is some data that shows that there is a bimodal distribution of ejection fraction, but there are plenty of people in the middle, and in fact you can see the patients with an ejection fraction of 40 to 50% are actually a significant number. The new guideline in 2013 actually recognizes this, and so instead of just talking about HFrEF, which are patients who have reduced ejection fraction measured at that time of less than or equal to 40%, there are also patients that have preserved ejection fraction, but they have some unique and possibly different subtypes. Those patients who always have a normal ejection fraction of greater than or equal to 50%, those people who kind of fall in between, where they have an ejection fraction of 45%, and some of these patients have been included in studies, HFpEF studies, and seem to act more like the normal ejection fraction or HFpEF patients than the HFrEF patients, although we don't have enough data to really say that for sure. And then finally, what about our patients who used to have an ejection fraction of 30 and now have an ejection fraction of 45 or 50? And these patients, we also don't know exactly what to do, but it has generally been suggested that they may have benefited from beta blocker and other therapies in the past, and so probably should be continued unless some obvious reversible process has been fixed. Reflecting this, the 2011 performance measure set reads as follows. The percentage of patients aged greater than 18 years with a diagnosis of heart failure with current or prior ejection fraction of less than 40% who were prescribed a beta blocker therapy with one of the three drugs we talked about, bisoprolol, carvedilol, or sustained-release metoprolol succinate, the long-acting, either within a 12-month period or when seen in the outpatient setting or at hospital discharge. So that language gives you, again, some flexibility and tries to reflect some of the data that I presented earlier. So in terms of coding instructions for contraindications, the acceptable contraindications that were added to recent iterations for evidence-based beta blocker measures include that it is extremely unlikely that all three evidence-based beta blockers would not be tolerated in a patient, but a non-evidence-based beta blocker would be tolerated. This scenario is so rare that there's not a need to separate contraindications by beta blocker class. So generally, the take-home I have for this is that Most people will tolerate a beta blocker eventually with starting at a low dose and slow titration, especially once their volume status has been stabilized and any acute exacerbants have been removed. Those people who do not tolerate one of the three evidence-based beta blockers generally don't tolerate any of them, and it should be very rare that you have a patient who, for example, did well on nebivolol but didn't do well on the other drugs. In my experience, I have one patient who insists that's true, but again, that should be an exception, not the norm. The next is that in extremely rare instance that all three evidence-based beta blockers are contraindicated in the patient, you can select yes if the contraindication is documented by a physician, APN or PA, and expressly references all three beta blocker medications. So no, the three accepted medications are all not tolerated, or reference to the contraindication specifically states that as a class, evidence-based beta blockers are contraindicated. And again, this should not be something that you routinely check off, and as a clinician, you should not try a drug once at a low dose, at a moderate dose, and then say patients are not tolerant. We often have to try and optimize other things and then go back and re-challenge with a beta blocker. Unacceptable contraindications are things that you should not write or not accept, is that cost is not an acceptable reason for not prescribing an evidence-based beta blocker at hospital discharge, and this is because these are some of the most inexpensive drugs that are out there, which is actually great for those of us who take care of heart failure patients. Secondly, heart failure patients with reduced ejection fraction may come into the hospital on non-evidence-based beta blocker therapy that is well tolerated. So not switching them and leaving them on those drugs is actually not an acceptable reason. So you would actually, if you had a patient come in on nebivolol, it would be your prerogative to try and change them over to an evidence-based beta blocker and somehow clinically show that they didn't tolerate the other ones. And again, that happening should be a rare case. So let me finish in the last couple of minutes with what we've been doing. I'm always motivated by these demotivations. This says challenges. I expected times like these, but never thought they'd be so bad, so long, and so frequent. And this demotivation I think of in response to the last 4 years that we've spent actually trying to do a better job of automating our process of prescribing beta blockers. But this one I actually think is a little more uplifting, which says limitations. Until you spread your wings, you'll have no idea how far you can walk. And you really can walk a long way in terms of quality improvement with heart failure, but it's typically the walking that you do is not what you initially thought. And most of the individual things that you take on at any point in time are going to be more challenging than I think any of us can initially expect. But if we look back at all the things we've done after we commit to them, it's usually pretty impressive at how far we can get. So here's my first practical view of my prescribing for beta blockers. Again, not all beta blockers are created equally. So we should use the ones and are, again, asked to use the ones that have good data behind them. Again, if anything, carvedilol is one of the best studied drugs, and the relative risk reductions seem to trend the most favorably. And this is carvedilol, for whatever reason, has generally been available on most of the low-cost prescription formularies, so including our local grocery stores here in Denver area, as well as the Walmart program and Walgreens and others. So for $4 a month or $10 for 3 months or whatever it is, most people can get access to twice-daily carvedilol at all the dosings that are available. Again, so cost and data are behind carvedilol, and I generally use carvedilol for those reasons. There are a couple of downsides to carvedilol. One is that it's twice-daily dosing. And we know that adherence is a critical issue for patients, and that adherence is not nearly as good as we would like it to be. And so if patients are on once daily dosing of everything else, and we then give them carvedilol twice daily, for some patients, that can be a reason to think of a once-daily dosing. Generally, a lot of my heart failure patients are on twice-daily dosing of other drugs, and if so, I think that this argument is less strong. And then finally, carvedilol is really a one-to-one non-beta selective drug. So patients who have bronchoreactivity or bronchoconstriction with a non-selective beta blocker like carvedilol may do better on a different drug that really is just beta-1 specific. So if you look down to number 3, bisoprolol, this is a highly beta-1 specific drug. It affects the beta-1 receptor, or is more avid for it by 130 to 1 compared to the beta-2 receptor. The other advantage of bisoprolol is that it's daily dosing. It's also been studied in the CBIS trials. And generally, it's generic and relatively well can be purchased for a low price. We've had a little bit of trouble in that some of the formularies for low-cost medicines have only provided bisoprolol as a combination drug with hydrochlorothiazide as a hypertension drug, and so occasionally that's created some issues with access. And then in between is metoprolol succinate extended release. Again, this is also a beta-1 selective drug, not quite as much as bisoprolol, but quite beta-1 selective. It's generally once daily dosing. Unfortunately, and I don't know the exact reasons, it's not generally been on some of the low-cost formularies. So even though it's a generic drug, a lot of times the copay out of pocket would be more in the $35 to $70 range. Although, again, it's often lowest tier for many patients. The other thing that I want to say is some people talk about the differences in heart rate and blood pressure response between these drugs, and I have to say that my personal experience and that of the data shows that it's not like carvedilol with its alpha-1 activity vastly drops the blood pressure compared to the other drugs. The second thing is that once you choose the drug you want, the strategy for getting there is important. We already talked about starting at relatively low doses, which I think is important because it increases your chance of success of a good start. The other is that if you give patients too high of a drug to start and they have side effects and low blood pressure, they may be less likely to be willing to re-challenge. So it is important, I think, to take the time to slowly start out and gradually increase. And then, obviously, these patients need to be monitored for a variety of potential side effects. And this Table 20 in the new guideline outlines a lot of those considerations. This is some of the only data that I know about starting slowly, is that patients, again, the studies done with beta blockers were generally in stable outpatients. And here we are taking care of inpatients with a recent exacerbation who may not be as stable. And the question is, should we wait and start beta blockers after discharge or start them in the hospital? And one of my mentors, Chris O'Connor in the Duke group, actually conducted a randomized study. It was published back in 2004, and they randomized a few hundred patients to either starting carvedilol prior to going home or asking that patients with a recent heart failure exacerbation go out of the hospital without beta blocker and then get started later when they were felt to be more stable. And what they found is the combination of two important endpoints. One is that starting the beta blocker prior to discharge did not appear to increase the risk of decompensation after discharge and readmission, which is a real concern with the 30-day readmission metrics. The second thing is that, as you might expect, patients who leave the hospital on a beta blocker are more likely 2 months later to be on a beta blocker than those patients who leave the hospital without one. And the rate was 91% of people were still on a beta blocker at 60 days. If they left with a prescription and taking beta blocker, then those patients who were asked to start one later after they'd seen their provider, which was only 73%. So I think that's important. We also, with all this concern about readmissions, we also looked in the Kaiser data and showed that of readmissions to the hospital after a heart failure hospitalization, only about 2 to 3% of patients had a beta blocker started or intensified prior to that. Just giving some reassurance that that patients who are getting rehospitalized, this is not because people are pushing their beta blockers up in the outpatient setting. And then finally, the last thing I want to talk about is some systems things that we've done using the electronic medical record. So one of the key pieces is that in order to make sure people are on a beta blocker prior to leaving the hospital, we have to know that they actually have heart failure. And a lot of people have struggled with knowing who it is that's going to ultimately be given a discharge diagnosis of heart failure, which doesn't actually occur in billing usually until 3 to multiple days after discharge has happened. So we've been using our Epic electronic medical record to identify patients who have one of the following 3 criteria: either an ICD-9 code in the past for heart failure, a BNP level over 150, or IV loop diuretic administration during the hospitalization. And if this happens during the hospitalization, a best practice alert in Epic is fired, and then ask the provider to consider whether this patient has heart failure, and if so, to use heart failure order sets that include the Get With the Guidelines measures. And so this is the best practice alert if a patient meets those criteria during hospitalization. So this is in real time during their real care. Providers have to recognize either, yeah, I'll use the heart failure order set, or this patient doesn't have heart failure, and has to say why. We actually have been looking at how well this performs. We looked at a 45-day period and found that essentially with those 3 criteria, we're identifying essentially everybody except for 1 or 2 people who have very extenuating circumstances who have heart failure. And then we're identifying some additional people who don't end up with a primary discharge diagnosis of heart failure, but about half these people actually have heart failure. So even though they don't fall into the primary discharge diagnosis bin and denominator, a lot of them actually should be getting heart failure measures anyway, and so we do a good job of identifying those patients, with only about a third of patients who really maybe shouldn't have had it fired on them, and so 2 out of 3 times people are getting, providers are being informed for the right reasons, and so we don't think we're causing too much fatigue. And then we leverage the EMR to suggest the Get With the Guidelines and American Heart Association orders. This isn't actually the beta blocker one, but it's quite similar. This is the ACE-ARB one, and it's asked them to prescribe it, or if not, they have to pick from among accepted contraindications. And we think not only does this help with documentation, it actually is a form of education in real time. There's some explanations about why people should be doing this, and it helps them understand what is a legitimate contraindication. And if they pick the contraindications, they're listed here. And again, I think that's helpful for education, particularly at an academic institution. So, and then finally, the big picture is that, again, our goal is to help patients do better, not to just check off boxes. And so we want patients not only to get prescriptions for beta blockers and get them at the right doses, but we also afterwards want them to take those drugs and then have them adjusted the way they should be adjusted. And so again, I think one of the ways to do this is to think about patients not in terms of just their disease, their heart disease, but think about them as people. And then think about not just about drugs, but actually the whole system of care for chronic illness that helps prescribe, deliver, and get people to take these drugs and then have adequate follow-up. And then finally, we want to have patients at the center of what we're doing, and we want to think about the characteristics of those patients, not only in terms of their medical illness and their heart failure, but their other illnesses, their demographics, their education level, and their behaviors. But again, that occurs in the system that we provide, not only in the hospital, but after discharge in the outpatient setting, and that all occurs in the environment that the patient lives in, and I think it's the environment that we probably forget the most. So with that, we've got about 10 minutes for questions, and I hope that was clear and helpful to people.
Great. Thank you, Dr. Allen. Feel free, if you have any questions, to go ahead and press *6 to open your line. Also, the questions that I've been getting in our GoToMeeting queue were about if the slides will be available after the webinar. Yes, I will be emailing those slides out by Wednesday. Also, we'll be posting a recording of the call to our website, too. So I'll email y'all all that information. Any questions, feel free to press *6.
While we're waiting for a question, I actually review all of the outliers after the fact for our Get With the guidelines, and probably the most common one that I've been seeing is patients who did not have a prior reduced ejection fraction. They have a heart attack, come in, get treated for that acute myocardial infarction, and then actually are meeting the MI metrics, but leave the hospital without a lot of heart failure, but with a reduced ejection fraction. And those patients are, for some reason at our institution, are getting low pressor. And I think that just has to do a little bit with focus and where those patients go to in terms of the providers and their familiarity. So one of the things we've had to do is for patients who are taking care of a lot of ischemic heart disease but not so much heart failure, is actually work on trying to switch over from a low pressor or metoprolol tartrate over to one of the 3 accepted drugs. And that can be a challenge. The other thing I didn't mention that we've been working on but has taken a lot of help from our health information technology group is to actually get our ejection fraction results field-coded in our system, which and then have those EF results uploaded into Epic to create a best practice alert related to the ejection fraction. And that's required a lot of work because the echo system, first off, the echo reporting didn't necessarily start off with field-coded ejection fractions for LVEF, and then once they were coded, that system didn't speak with Epic very well to start off with. But we've actually made progress with that and are just now starting to create best practice alerts off the EF. So if the EF is 40 or less, it creates a notification to the provider and can check to see whether the quality metrics based on ejection fraction are being met. But again, that requires a lot of help and is not something a clinician can do on their own unless they have a lot of HIT experience.
All right, we did have a question come in. Dr. Allen, can you speak to the interaction between green tea and beta blockers?
So I actually I'm not an expert on other drugs. I do know that when we talk about caffeine, obviously caffeine is a stimulant, and so sometimes we do give recommendations around curtailing the total amount of caffeine that people have, although there's not a lot of data out there on that. The interactions between different foods and beta blockers in terms of metabolism, I can't speak to myself. We actually are fortunate in our transplant program to have a pharmacologist who does help keep up on these things. Can they clarify what the concern was?
Nancy, if you'd like to come off mute and ask any follow-up questions, it was *6 to unmute your line. Nope, I think...
Can you hear us?
Yeah. Yes.
Okay, Elaine Pursuti has the question. I'm going to turn it over to her.
Okay, Elaine?
Yes, I recently read a news article regarding green tea's effects with beta blockers, that it reduces the effect of the beta blocker, and supposedly there is a study that was done regarding the interaction.
I would have to look it up, but I'd be happy to do so and get back to you on that.
we had another question come in our queue. Do you follow up patients when they are discharged? And if so, who does the contacting?
I'm sorry, say that again. Who does
do you follow up with patients after they're discharged? And if so, who's the one contacting them?
Yeah, so actually that's a very complicated and loaded question. So a couple of things. One is that one of the first things that we did as part of our quality measures is to make sure that patients were getting a follow-up appointment scheduled at the time of discharge, and we've generally followed the recommendation to try and do that in 7 days for most patients, given their acuity, although there's never been a randomized trial of that. So that's part of our order sets now, and that's been pretty successful, and we track that. The second issue is that follow-up depends in part on the patient and who follows them and what kind of heart failure they have. So about a third of our heart failure patients are plugged into our advanced heart failure clinic, and we have good control over those patients and getting appointments for them. Another third of our patients are followed at our institution but not by the advanced heart failure clinic, and so we've had to work with primary care providers as well as some of the non-heart failure cardiologists to ensure follow-up. And then finally, another third of our patients are actually referred in from out of our network or out of our provider location. And so, we've worked to get appointments, follow-up appointments with those patients with their outside providers, but it obviously poses different challenges. And so we've done a number of things around making sure that happens, that those phone calls are made, and that common providers we've actually interfaced with. Epic has also allowed us to do a better job of sending discharge summaries to people to facilitate the communication for that follow-up. The second thing is that we've worked a lot with phone calls. I think phone calls are somewhat controversial. There's been a number of observational data about whether they're helpful or not helpful. One randomized trial that was of borderline significance. And then actually phone calls can get tricky because if you call patients 24 to 72 hours after discharge, the level of questions that they can ask can actually be really complicated. So you have to be careful if you're having those post-discharge follow-up phone calls to have people on the phone who know either how to answer some of those questions and or who are very good at knowing when to refer those questions to a nurse or even a physician. So that can be challenging. And then in addition to that, our system decided to do post-discharge follow-up phone calls for all patients related to quality and follow-up. And so we had to create a system where we didn't have a post-discharge heart failure call, a post-discharge diabetes call, and a post-discharge health system general call so that people were getting barraged by phone calls. So organizing those calls is actually an important step, and so fortunately we had some good leadership that helped work with that. So those are kind of the two main pieces of follow-up, and they're very complicated, but obviously important.
Great. Any other questions from the phone lines?
I actually just looked up the green tea study, and it was actually that green tea may affect the metabolism of nadolol, and it was actually in a pretty small number of patients. So I think it's a great question. It sounds like that we should obviously, in general, be aware of possible interactions between foods and herbal supplements and the drugs that people take. It looks like this is an area that we don't have a great answer for yet, though.
Great. Okay, we have one more question come through the online tool.
Can you read that question? I can't see them.
It was the same one.
Okay.
So I don't see any other questions outstanding for us.
All right, well, it's 1 o'clock, so.
Thank you all so much, Dr. Allen. Thank you for your time. And again, this last slide right here that Dr. Allen just pulled up actually gives you the contact information for your QI staff in your specific market. So feel free to reach out to them. This will also be a part of the slides that we email out later on this week. So thank you all so much for your time, and we look forward to having you all on our next webinar. Thanks so much.